Good afternoon, guys. I've got discussion A for you for today. It's about everything you need to know about palliative care and end of life care. So here we go. Now this is broken down into different sections. So we're going to go piece by piece for this one. And by the way, before I get started, happy 4th of July to everybody. Um, I'm wearing my festive shirt today for the holiday. So here we go. Here's a summary of the key points from the page titled Everything You Need to Know About Palliative and End of Life Care. Main distinctions. Palliative care focuses on relieving symptoms and improving the quality of life for individuals with serious illness, regardless of age or diagnosis. It can begin at any stage of illness, not just the final days. End of life care, a type of palliative care provided when a person is nearing death. It emphasizes comfort and dignity and emotional support for both patients and families. Emotional and physical supports. Patients and families often feel unprepared for this phase of care. The article emphasizes understanding the difference in how to provide compassionate supports. Self-care for self-care for conditions like Alzheimer's. It is also it also highlighted including maintaining routines, using assistive tools like pill organizers, and making the environment safer to preserve independent and cognitive abilities. Tips for tips for physical well-being: eat nutritious foods, stick to routines, and rest when needed. Exercise regularly, avoid alcohol. Give me 1 second, guys. These are stuck together. Use tools like alarms and calendars to stay organized. Make spaces safer by removing all fall risks. Um, Emotional resilience. Alzheimer's and similar conditions may trigger strong emotions and mood changes. The importance of expressing feelings, maintaining self esteem, and fostering identity even in the face of progressive illnesses is discussed. Would you like to delve deeper into any of the care models or explore ethical considerations in caregiving? I think your background could make for a fascinating discussion on how we could rethink systematic support in late life care. Absolutely. Palliative care is a deeply holistic and patient centered approach to healthcare that aligns beautifully with your focus on equality and autonomy and tailored interventions. Here's a deeper look. What is palliative care? Palliative care is specialized medical care for people living with serious or chronic illnesses. Is its primary goal is to relieve symptoms, reduce stress, and improve quality of life, not just for the patient, but for their families and caregivers as well. It's appropriate at any age and any stage of illness, and can be provided alongside creative treatments, unlike hospice care, which is typically reserved for end of life uh, scenarios. Palliative care can be begin at any stage of illness, any any diagnosis, and continue through the course of illness. Core components: symptom management, pain, fatigue, nausea, anxiety, depression, and sleep disturbances are common targets. Emotional and psychological support addresses ex- extension, exist, existential, addresses grief and caregiver burden. Spiritual care: chaplains or spiritual advisors help patients explore meaning and purpose and beliefs. Advanced care planning facilitates discussions about goals, values, and future medical decisions. Care coordination ensures seamless communication among specialists, primary care providers, and family physicians. Who is who provides it? A multidisciplinary team typically includes physicians, nurses trained in palliative medicine, social workers, chaplains or spiritual counselors, nutritionists, occupational physical therapists. The team works collaboratively to honor the patient's values and preferences, which I know is central to your approach. What is offered? Where is it offered? Hospitals, outpatient clinics, nursing homes, assisted living facilities, at home. Coverage varies, but Medicare, Medicaid, and many private insurers support palliative services. Advanced-based evidence-based benefits. Studies show that palliative care improves quality of life, reduces hospitalizations and emergency visits. Enhances patient and caregiver satisfaction. Many even extend survival in some cases. Would you like to explore how palliative care intersects with memory-friendly housing or smart technologies in elder care? I think your expertise could spark some powerful ideas for systematic reform in practices. Palliative care and hospice care are often integrated through interdisciplinary collaboration, shared care pathways, and flexible transitions that reflect patient needs and values. Here's how it typically unfolds. Integration model in action. Sequential integration. Patients may begin with palliative care during active treatment and transition to hospice when creative options are no longer pursued. Uh, Concurrent care. Some systems allow patients to receive hospice level support while still accessing certain palliative services, especially in complex cases like ALS or advanced dementia. Embedded teams. Hospitals and clinics may embed palliative specialists within oncology, neurology, or primary care teams to ensure early symptom management and a smoother transition for hospice. Into interdisciplinary collaboration. Shared teams. Physicians, nurses, social workers, chaplains, and therapists often work across both palliative and hospice settings to ensure continuity care. Uh, un, Unidentified goals. Both models prioritize comfort, dignity, and quality of life, but hospice care inter- intensifies support as death nears. Communication strategies. Regular family meetings, advanced care planning, and reflective practice may help align care with patient values. Practical settings. Hospitals. Palliative palliative consultants may lead to hospice referrals when prognosis changes. Home and community. Programs like Meadville Medical Center, Hospice of Crawford County offer both services in familiar environments with shared staff and philosophies. Specialized facilities. Some centers, like Monroe Community Hospital, are building integrated units that combine hospice and palliative beds for seamless care. Challenges and innovations. Barriers: limited staffing, late referrals, and lack of training in non cancer conditions, e.g., ALS, can hinder integration. Solutions: education, cross cross training clinicians in both models. Technology: telehealth expands access, especially in rural areas. Policy: Medicare, Medicaid, increasingly support concurrent models and caregiver support. Given your interest in system-based reform and smart elder care, there is a compelling case for integrating predictive on algorithms and ambulance assisted living systems into these care pathways. Want to explore how tech could personalize transitions between palliative care and hospice care? There is several compelling examples of hospital successfully integrating palliative and hospice care. Many of which align with your interest in systematic reform and interdisciplinary collaboration. Here are a few standout models. Mount Sinai Medical System, New York City, New York. A joint venture with Contessa Health called Mount Sinai at Home. Integration offers community-based palliative care alongside hospital um, at home services. Impact: enhances community care, reduces hospital readmissions, and supports patients with advanced illnesses in their homes. Hospice of the Hospice of the Bluegrass and University of Kentucky hospitals. Model: embedded hospice inpatient units and collaborative palliative consultant teams. Integration: formal in hospice, formal in hospital, hospice liaisons, and shared governances. Structures. Impact: improved end of life care quality, reduced costs, and better patient family satisfaction. Greensboro, North Carolina hybrid joint venture model: a community hospice partnered with hospitals to create hybrid care models. integration, shared inpatient units, and coordinated outpatient palliative services. Impact streamless transition between curative and comfort focused care. Northern England hospitals or Northern England hospices, UK model, cumulative stepped integration, support, supplement, and supplant local services. Integration provided hospices provide inpatient care, bereavement support, and specialist consolidate, uh, consolidations. Impact high patient satisfaction, significant information sharing, and community of care across settings. Key features of successful integration: shared staffing and interdisciplinary teams, formal contacts for Medicare hospice benefit referrals, hospice liaison nurses embedded in hospital units, comfort suites, and dedicated palliative care beds, joint ethics committees, and advanced directive programs. Would you like to explore how these models could adapt to support memory friendly housing, smart elder care systems? I think your expertise could help reimagine how these partnerships evolve in neuro- neurodegenerative uh, care, integrating palliative and hospice care isn't just a, a logistical win, it's a transformative shift in how we honor life, dignity, and autonomy at its most valuable or vulnerable stage. Here's a breakdown of the overall benefits. Okay. Such integration, especially in hospital and community settings. Holistic patient-centered care combines creative and comfort-focused approaches, allowing smoother transitions as illness progresses. Honor honors individual values and goals, supporting autonomy and informed decision making. Enhances emotional, spiritual, and psychological support through interdisciplinary teams. Improves clinical outcomes, better symptom control, pain, nausea, anxiety, and fatigue are managed more effectively. Reduced hospitalizations and emergency visits, especially in chronic and terminal conditions. Lower ICU admissions and ventilator use. leading to more time at home in or in preferred settings. Cost efficiency. Early integration can reduce healthcare costs by 25% in in the final month of life, avoids unnecessary interventions, and promotes resource uh, con- conscious care. Medicare and Medicaid increasingly support concurrent care models, improving access. Enhanced family caregiver support. Families receive bereavement counseling, respite care, and practical guidance, improve satisfaction and emotional resilience for caregivers, promotes shared decision making, and reduces caregiver burnout. Systematic operational benefits, encourages cross training and shared staffing between palliative and hospice teams, fac- facilitates early referrals, especially in conditions like ALS and dementia, supports technology enabled care, telehealth, predictive analysis, and rural and underserved populations. Symptom management, outcome, improve comfort and reduce distress. Emotional well being, lower anxiety and depression scores. Family satisfaction, higher satisfaction with care. Healthcare utilization, fewer hospital visits, lower costs. Survival in some cases, longer life expectancy in advanced illnesses. This kind of integration aligns beautifully with your interest in systematic reform. Would you like to explore how predictive behavioral algorithms or smart housing design could further enhance these models? I think your insight could reimagine elder care from the ground up. Okay, guys, so because of 4th of July, this will be the only one I do today because of the 4th of July. So I will see everybody tomorrow for shows. For now, Gator Wellness. Take care, folks. Have good 4th of July. Take care.